Hi, everyone. So, no high hopes. Dr. Dow was just being very kind, and I'm just a simple heart plumber. So, be patient with me as I go through ECMO. You guys will probably know more about ECMO and in VV ECMO than me. Again, the objective of this talk, we're going to just focus it on VV ECMO because this is a pulmonary conference, but ECMO really has evolved significantly and is truly helping patients from a whole spectrum, including what we know as arterial ECMO. And the data is very promising, and I think is a great adjuvant for patient survival nowadays. But because of time limitations, we're just going to keep it focused to the lungs today. So what is ECMO? So ECMO is the use of extracorporeal circulation and gas exchange to help provide temporary life support in patients that have reversible pulmonary or cardiac failure. And really the goals are to ensure adequate oxygenation, and it's not intended to treat the lungs or to treat the heart. It's really there to allow the lungs and the heart to have some time to rest so the patient can recover. It also helps to reduce the ventilatory settings to values that will not end up damaging the lungs, and also to help to reduce the pressure requirement on these patients. So the principle, as complicated as it sounds, is very simple. It's just getting the saturated blood, getting it drained from the body, removing the CO2, and then adding the O2 and returning the blood to the body. And that's pretty much really the essence of ECMO. So whenever I used to think about ECMO, this was the thing that will come into my head, and probably it's still the same, but it has really evolved tremendously in the last 50 years to the point that it's now much simpler, and you will see what I mean in a few minutes, but in terms of the physiology and everything, is still less complicated than this picture. But to have a little understanding on what ECMO is, on how it has evolved in the past few decades, we're going to start kind of just to give you an idea of timelines on when or how the technology was developed. So it all started in the 1950s when it was the development of the membrane oxygenator in the laboratory. And then a good numbers of years went by where they started to test this, and there was animal testing and good studies on dogs that they used for this. And it wasn't until 1971 that the first successful case was done by Bill and Branson. And following this case, then there was in 1972, the first successful pediatric cardiac case by Bartlett and Gazzaniga. And then a few years later, 1975, then probably you are familiarized with this because the first thing that comes into Google when we start searching about ECMO, the first neonatal case by Bartlett and Gazzaniga, Esperanza. So there is a picture of Esperanza at which was less than 12 months old, and then a picture at 21 years of age after her survival. So, it was a very flourishing technology, and when it went back to 1979, there was a trial done in 9 different centers, and the trial demonstrated only a 10% survival. And this really impacted the evolution of ECMO and halted it at least for a decade. It really brought the technology down. It really halted the research on ECMO, especially on ARDS in adults. And after reading much about how this study was done, it is, most people will conclude that, it was a technology that was just flourishing. It was in its early beginnings, and they conducted it in some centers that really didn't have enough experience. So it was more on how the study was designed more than the results that they got, but it definitely had a major impact on the evolution of this technology. Then in 1988, there was cases. Most of them were pediatric cases because the pediatric survival was still pretty good with ECMO. So the technology really evolved within the pediatric population. Then in 1981, the Extracorporeal Life Support Organization was formed. And this has been the major registry since then. And this is pretty much it also has become the organization that follows, registry data and pretty much dictates and based on their collected data, the indications of ECMO nowadays. So in the 1990s, ECMO was standard practice for the pediatric population in centers that were experienced and were doing it. And it wasn't until 1997 that Bartlett decided to conduct another study of 100 cases and was able to demonstrate 54% survival. And this pretty much revamped or revived the use of ECMO in the adult population. So in the 2000s or early 2000s, ECMO was being done standard in a few cases, or not few cases, in some centers that were having experience with ECMO, but it wasn't really until 2009 that the first randomized controlled trial, CSAR, was performed. And it wasn't a big number of cases like the trials that we do nowadays, but it was enough to demonstrate the value of ECMO in this patient population. So they were able to randomize patients, about 50 patients in the ECMO arm versus a little lower amount of patients on the conventional arm, conventional ventilation arm, and demonstrated a 63% survival. So this really kind of revamped the whole hope and belief on ECMO and lead the way for other randomized trials to take place. So going back to that slide a few slides ago, we can see how ECMO has evolved. And from that first case that was done back in the 1970s, now if you look at the ECMO equipment, it has really simplified a whole lot. And it was all because of the studies that started to have place after Bartlett was able to demonstrate that ECMO was actually useful for ARDS and adult patients. So current applications, is being used in cardiac surgery. That's pretty much ECMO is like a little modification of heart-lung machines for our CT surgeons. Is being used in cardiology, intensive care, and emergency medicine. There are centers that really even start ECMO on the field and bring patients to the unit afterwards. So nowadays, it really has evolved to this technology being done at bedsides, whenever it's done, because the earlier you can initiate it in the proper settings, the better survival for the patients. So it's usually done as a bridge to recovery or decision making, or even for patients that will need some sort of LVAD or heart or lung transplant. The types of ECMO, we have venous ECMO, and we'll talk about that so you understand what that means in a little bit, and venous arterial. Due to the time restrictions that we have, I'm just going to skip anything venous arterial for this talk and just concentrate on venous ECMO. So our VV ECMO is pretty much indicated for severe respiratory failure, and again, we are taking blood from the venous or central venous side, getting it processed, getting it oxygenated, and then returning it to a central vein. So there's several different configurations. The most common one is femoral. So again, we got cannulas that go on the femoral vein, get the blood extracted from the body, get it oxygenated, and then return to the contralateral femoral vein. There are certain variations on these. One of the advantages is it's very quick for the access input, and it allows for patients that need to have, it's easier for them to get CRRT. The disadvantages is that you have limited maximum flow rates, and patients have to be, of course, bed bound, and you'll see a picture and understand why in a second. High flow ECMO, so advantages is it allows for a higher flow circuit, and it's required when you have a single cannula that is inadequate to maintain good blood flow. But the advantages is that by adding that third cannula, then you're really occupying 3 veins, and it's complex to secure. And back in the days, more than now, the bleeding and vascular complications were the main issues with ECMO. That has evolved quite a bit in the past few years, but it's still something that we get concerned of. So again, another configuration is to having 2-stage single cannula. So there are cannulas nowadays that are developed for a single cannula to have different lumens, so you can extract the blood same cannula, but just having lumens at different anatomical sites. Now, again, the advantage is that you're only having one access size. The advantage is that, it could limit the use of CRRT, but also you may, if you don't have adequate flows, you may need to still add another cannula to provide that. And the most commonly used VV ECMO configuration by collected data is the femoral jugular, where you get the access cannula on the femoral vein and then the return cannula on the IJ vein. And usually these cannulas, to give you an idea, are huge cannulas. They're probably about 20 French, or at least, at the very least, 19 to 24 French or so. So the advantage of this configuration is that it can provide really adequate flows, it's safe to insert, and it really allows for CRRT. The advantage is that, again, everybody gets always concerned of patients being moved and then losing access size and bleeding. So I'm just going to skip this because this is all VA ECMO, but let's talk about a little bit of the components of ECMO. Again, we talked about blood coming out of the body. There is some tubing that goes connected to the cannula, and then, I have a marker here. So the blood gets processed through a pump, and we'll talk about this in a second, and then goes into the oxygenator. In pediatrics, there is a different element which helps to, is like the heat exchangers. In adults, this is all one single unit with the membrane oxygenator. And then after the blood is oxygenated and heated, then it returns to the body. So the centrifugal pumps have really evolved in the last several years. We used to have roller pumps. Nowadays, pretty much everything is just a centrifugal pump. It really ensures a perfusion pressure. It can really provide good perfusion pressure up to 4,000 RPMs. It can deliver flow up to 8 liters per minute, and the pump can function for up to 21 days. The membrane oxygenator, back in the days, this is really a little membrane that allows for gas exchange. And back in the days, it used to be silicone. Now we have evolved to the use of hollow fiber, and it's really polymethylpentene. And the major advantages is that really provides minimal membrane leakage and low resistance to blood flow while going through the membrane. And then, as I mentioned before, in adults, this is all comprised in the same element, is separated in pediatrics, but the heat exchangers pretty much is there to ensure that the temperature is regulated, being the same needed for the body while the blood is transiting in the extracorporeal circuit. So another component is the central unit controller, and then we'll have the panels there to help us control our pressure and our gas monitoring. And then you have a little bit on the right side picture that shows you all the different types of cannulas that are being used nowadays for ECMO. So when we talk about some of the complications that I mentioned before, bleeding, losing access site, and securing this cannula is a big one. And you can see on all of those pictures, one of the most important things is making sure that those cannulas are very well secure. And in the case of VA ECMO, then we always are concerned about patency of arterial flow to the rest of the limb, but that's not a big issue on venous ECMO. But we really need to make sure that these huge cannulas are very well secure, because any little movement, if they're out, then that's when we run into trouble. So factors determining gas exchange for the oxygen exchange, we know that it will depend definitely on the type of membrane that is being used and the diffusion characteristics of this membrane, the thickness of the blood pathway, the surface area of the membrane, the FiO2 in the gas phase, and then the rate of blood flow. And for the CO2 to be extracted, then the difference in the CO2 concentration, again, the same size of the membrane, and blood pathway thickness, and blood flow rates. So this is how ECMO is set up. It's very similar to our little diagram on the right, but you can see here, this is the centrifugal pump. This is set up for adults because we don't see the heat exchange. It's usually like a big box for the pediatric right behind the oxygenator. You can see the oxygenator right here on blue. And then the rest of it is going to be the tubing that helps the blood transit to the ECMO needed pump and oxygenator devices. So how do we decide which patients are going to be needed? The score is very important. It's called the Murray score, and it's pretty much consistent on getting a few set of values. And The value of the score is going to tell us if these patients are either candidate or have a definitive indication for ECMO. So things that are included or taken into consideration, and of course the oxygen concentration, findings on the chest X-ray, PEEP, and then compliance on the ventilatory settings. Now, depending on not only scores, but just for those trials that I mentioned before, they may have used different indications that the indications that are now there outside by, not outside, but at least publicated by ELSO. So I wanted to include all of these indications because I think, the results of the trials with great survival were based on these indications. So depending on the patient, if they meet any of the other indications criteria, I think it is important to have them. So if you search, you're going to see indications by ECMONet. ECMONet was a study done in about 60 patients during the H1N1 pandemic. And they were able to demonstrate great survival. And they were using other elements that included some of our normal lab values, creatinine, renal function, bilirubin, and they were able to actually validate a score not only for indication, but they were able to validate predictors of mortality. So in their ECMONet score, anything above 4.5% was pretty much their cutoff to high mortality risk prediction. Another study that you guys are probably gonna see jump off because it's another randomized trial is the OLEUS study. So this was most recent, published in 2018. It's pretty similar to CSAR, but way larger number of patients. About 124 patients were randomized on each arm. And similar to CSAR, they were able to demonstrate greater survival in the ECMO group, but this is probably the largest randomized study done today. And here, just because we have the indications based on these studies, and so I just wanted to put them all in a little summary for you. But regularly, when you are trying to develop a program, most people will just base their indications on the ELSO criteria, and they pretty much focus their indications on first the mortality, the estimated mortality of the patients, and then the MORE score. If the MORE score is 2 to 3 patients and have a mortality over 50%, and again, this is for reversible causes, then they can be considered a candidate. If their mortality is over 80% and a MORE score is over 3, then they definitely are candidate for ECMOs. And again, contraindications is having conditions that are really irreversible or not compatible with long survival. So some of these conditions or indications for ECMO include ARDS, severe pneumonias, severe acute asthma, hypersensitivity pneumonitis, near drowning, lung contusion, and any of some sort of autoimmune disease affecting the lungs. Now, there's some irreversible chronic respiratory conditions in which ECMO can be considered, and will only be those conditions where the patient is being considered to either have a lung assist device or they're just waiting for transplant. Now, contraindications, and these contraindications are based on data, on mortality data. Prolonged mechanical ventilation over 14 days is relative. Severe chronic lung disease, witness cardiac arrest for over 30 minutes, CPR for over 30 minutes, immunosuppression, severe coagulopathic disorder. These are all relative but absolute. If you really have significant neurological injury or active bleeding or coagulopathies or terminal disease, then probably ECMO will not be the best solution for those patients. Now, when ECMO can go wrong, when we have the wrong configuration, then that probably will lead to fail in ECMO. Out of hospital arrest, again, CPR for over 50 minutes, refractory septic shock, patients that are older with severe ARDS, patients that have ARDS with severe multi-organ failure, and then if you have prolonged pre-ECMO mechanical ventilation. Some things to think about is mechanical ventilation is to be continued at all times during ECMO. The flow can be very volume dependent, and the ECMO flow will always drop if there is hypovolemia or the cannulas, there is malposition on the ECMO cannulas in the case of hemothorax or pericardial tamponade. we already kind of mentioned on this. You got blood that is being removed, blood that is being reinserted in the body. So it really has very little impact on preload. It indirectly affects cardiac function, because the oxygenation will definitely help to reduce vasoconstrictions and will help to improve RV function. So it doesn't really have a direct effect on LV function, but by improving RV function, then you can see an improvement in the LV function just because of ventricular interdependence. The blood flow rates of ECMO are between 3 and 6 are considered acceptable for arterial oxygenation. The aim for ECMO is to get the pump flow to provide at least more than 60% of cardiac output with saturation of over 88%. For venous ECMO, patients should, usually the oxygen saturation is between 55 and 90 millimeters of pressure. And then it always will depend on cardiac output, the hemoglobin concentration, and oxygen saturation. Now, anytime that we find a patient that is candidate for ECMO and we are going to consider initiating ECMO, patients need to be anticoagulated, and the best anticoagulant is using unfractionated heparin. After cannulation, then once we are ready to start the ECMO circuit, the pumps get started and the flow, we started at 20 mLs per kil per minute, and then we gradually go up every 5 to 10 minutes by increasing 10 mLs per kil per minute until you reach the desired flow. Then the gas flow to blood ratio is adjusted 0.5 to 1, and you can start as low as FiO2 of 21% and increase your weight slowly until you reach your 100% FiO2. Once your desired flow is achieved, then you can start lowering your ventilatory settings to baseline. So a reasonable target for venous ECMO is keeping the hemoglobin saturation above 75%. And then adequate tissue perfusion is going to be always determined by your arterial blood pressure, venous oxygenation, and your lactate levels. So after we initiate ECMO, what do we look for? So you always have to have continuous venous oximetry, your vital signs. There's going to be continuous monitoring of pressures and the pre and post ECMO pump pressures, flow rates, and of course neurological and vascular status. And of course making sure that the patient is anticoagulated, and heparin will try to keep an ACT between 180 and 210. So once the patient starts to get better, how do we know how to wean ECMO? So of course we have to make sure that there is clinical improvement. We look at the chest x-rays, we look at all of our hemodynamic assessments. And once we are thinking that the patient is ready to be weaned out, we start the trials. Now, it's always recommended to do at least 1 or more trials before taking the patient permanently off ECMO. We usually start doing this by decreasing the flow, 1 liter per minute, a FiO2 of 100%, and going progressively to 2 liters per minute until you get a reduction of the gas FiO2 to maintain the SATs above 95%. Once you're able to maintain your SATs above 95% and the patient remains stable, then you can actually start your trials. And the whole purpose of the trial is to eliminate all the countercurrent sweet gas through the oxygenator while maintaining your oxygen levels stable. So complications, bleeding, thromboembolism, cannulation related, again, vascular is the biggest thing, heparin-induced thrombocytopenia, and of course neurologic complications. So for venous ECMO, one of the most commonly related complications in terms of cannulations is recirculation. And this happens when you have the reinserted blood just bypassing this systemic circulation and going again into the ECMO circuit. And one way to reduce this is by inserting a third cannula, or even adjusting the distances between the insert cannula and the access cannula and the insert cannula to allow the blood to circulate appropriately. So this will be all. Any questions?